She's 72. New diagnosis of AFib. Nobody runs her CHADS₂ score before she is discharged. It doesn't just happen. 8 weeks later, she has a stroke. That's a 5-minute calculation that would have caught it. That's not a rare miss. That's a Tuesday, and it's exactly why this video exists. I am Dr. Anderson, this is Note to Pharm.D, and today we're breaking down stroke prevention in AFib, how to actually risk stratify, and how to pick the right agent once you know the number. Here's a roadmap for this one. We're covering two things first: how to actually risk stratify a patient with CHADS₂ and why it replaced CHADS₂ everywhere that matters. Second, we're getting into DOAC selection and dosing, and what the landmark trials actually tells us and don't tell us about choosing one agent over the other. Let's start with CHADS₂ over CHADS₂. The reason this switch happened isn't cosmetic. CHADS₂ adds three things CHADS₂ misses: ages 65 to 74, female sex, and a history of vascular disease. And here's the number that actually matters clinically. A CHADS₂ score of 0 means a true 0% annual stroke risk. A CHADS₂ can't make that same claim. A CHADS₂ score of 0 or 1 still carries a real-world stroke risk of 2 to 3%, which makes it nearly useless for identifying who's actually safe to leave off anticoagulation. That's why the 2023 ACC/AHA/ACCP/HRS guidelines leans specifically on CHADS₂-VASc with clear thresholds. Annual risk of 2% or more, oral anticoagulation is recommended, and a DOAC is preferred over warfarin in DOAC-eligible patients. Annual risk of 1 to 2%, oral anticoagulation is reasonable but not mandatory. That's where shared decision-making comes in. One more thing before we move on: bleeding risk scores. Has bled and its cousins discriminate poorly between who will and won't bleed, largely because they share risk factors with the stroke risk scores themselves. So don't use them as a gatekeeper. Use them to find modifiable risk factors. Is the patient on an NSAID they don't need? Is their blood pressure poorly controlled? And fix those, rather than withholding anticoagulation from someone who's actually high risk. Now, to put some numbers behind why this matters at all, AFib increases stroke risk 5-fold compared to patients without it. AFib is responsible for 15% of all strokes, and 90% of the thrombi that actually form do so in the left atrial appendage, which is exactly why we care so much about getting this decision right. Quick practice pro before we move on. The CHADS₂ score isn't sex neutral in how it's applied. A woman with a score of 1 from sex category alone and no other risk factors is actually treated as low risk in most guideline language. Don't let that single point push you into anticoagulating someone who doesn't need it. Read the whole patient and not just a number. So why does CHADS₂ win mechanically? It comes down to resolution at the low end. A CHADS₂ score of 0 still leaves you with a meaningful stroke risk you can't really act on with confidence. CHADS₂ actually splits that population. A score of 0 really is 0 risk, and a score of 1 is 1.3%. That's a real usable low risk category, and it's the reason the current AF guideline specifically calls it out by name. Here, the direct language from the guideline. A validated clinical risk score, such as CHADS₂ should be used to evaluate annual risk of a thromboembolic event. That's not a suggestion buried in a footnote. That is a Class 1 recommendation. If you remember one thing from this section, it's this. The CHADS₂ isn't just the newer score. It's the score that actually tells you when 0 means 0. Okay, now let's talk about actually picking and dosing an agent. 4 DOACs are approved for AFib. Dabigatran, which is a direct factor 2A inhibitor, and rivaroxaban, apixaban, and edoxaban, which are all factor 10A inhibitors. All 4 are non-inferior to warfarin for stroke prevention. That part is settled. Where people get tripped up in dosing, especially with apixaban, its reduced dose, 2.5 milligrams twice daily, isn't triggered by renal function alone. It requires meeting 2 of 3 criteria: age 80 or older, weight 60 kilos or less, or a serum creatinine of 1.5 or higher. The other 3 agents key their dose reduction off creatinine clearance alone, which is a genuinely different decision rule. So don't apply the apixaban logic to rivaroxaban or edoxaban by habit. And if your patient is still on warfarin, remember, well-managed VKA therapy means a time in therapeutic range greater than 65 to 70%. If you're below that, the first move isn't switching agents. It's fixing adherence, diet consistency, and drug interactions first. A couple more numbers worth anchoring. The INR target for non-valvular AFib is 2.0 to 3.0. Across the DOAC trials, all 4 agents reduced all-cause mortality by roughly 10% compared to warfarin. But apixaban was the only one to hit statistical significance on that endpoint specifically. Here's a real-world scenario worth having ready. An 82-year-old woman, 61 kilos, serum creatinine of 1.6 on apixaban. That's all 3 of the reduced dose criteria met. So she gets 2.5 milligrams twice daily. Now swap her onto rivaroxaban instead. Her creatinine clearance comes back at 45. So she gets 15 milligrams reduced dose based on renal function alone, completely independent of her age or her weight. Same patient, 2 different decision rules. That's exactly the kind of switch that trip people up on rounds. Let's talk about what the landmark trials actually showed, because this is where I see the most confusion. Every single DOAC significantly reduced intracranial hemorrhage compared to warfarin. That's one of the benefit held consistently across the RELY, Rocket AF, Aristotle, and Engage AF, TIMI 48 trials. That's the headline, cross-trial win. Beyond that, it gets agent-specific. Dabigatran was the only DOAC to significantly reduce ischemic stroke on its own in RELY. Apixaban and edoxaban significantly reduced major bleeding. But here's the trap. Don't cross-compare these trials to rank the drugs against each other. The Rocket AF enrolled a meaningfully sicker population with a mean CHADS₂ score of 3.5 compared to roughly 2.1 in the Aristotle and the Relay trial. Different baseline risk, different trial design, different bleeding definitions. Claiming apixaban is more effective than rivaroxaban because of a 0.3% difference across two separate trials isn't something that data actually supports. The direct quote to remember: all the DOACs showed a significantly lower rate of intracranial hemorrhage than warfarin, the one benefit that held across every trial. Everything past that needs a head-to-head trial that we currently do not have. Now let's bring it home with 3 takeaways. 1. CHADS₂ not CHADS₂, is the guideline preferred tool specifically because it identifies a real, usable low-risk group at the score 0 level. 2. DOACs are non-inferior to warfarin across the board and consistently cut intracranial hemorrhage. Pick your dose based on renal function and drug interactions. And remember, apixaban reduced dose criteria are different from the others. 3. Bleeding risk scores exist to find modifiable risk factors. Full stop. They are never a reason to withhold anticoagulation from a patient who actually needs it. And that's stroke prevention in AF. Next up in this series, we're covering anticoagulation in valvular heart disease, where the rules change again. If this was helpful, like the video, drop a comment with your questions, and subscribe so you don't miss the rest of the series. See you in the next one.